Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. We are continuing our respiratory pathology series. This will be respiratory pathology episode part 3. And just like we do in the other episodes, we will discuss several very high yield concepts and conditions that are tested on the USMLE Step 1. Let's start with ARDS, that stands for Acute Respiratory Distress Syndrome. First of all, we should define what can cause the ARDS. The most common cause of ARDS is... Do you have the answer in that, Zoo Assembliers? I hope you're saying that that's the sepsis. And if you are saying sepsis, you are absolutely right. But other than sepsis, ARDS can occur in case of respiratory insult, in a sense of aspiration or pneumonia. And interestingly, pancreatitis is another cause of ARDS. The mechanism here is that the amylase, lipase, and all the other pancreatic enzymes go into the bloodstream from the inflamed pancreas in the setting of the acute pancreatitis, and then they cause the ARDS. We will talk about the exact pathophysiology of ARDS right now. We already mentioned the causes of the ARDS, but all of those causes have a common pathway of causing the ARDS. There is an alveolar insult due to some cause, and then this alveolar insult results in generalized inflammatory state in the body, which in turn releases the pro-inflammatory cytokines like interleukin-1, tumor necrosis factor alpha, and etc. And those pro-inflammatory cytokines collectively cause the recruitment of the neutrophils to the pulmonary capillaries. When those neutrophils reach the pulmonary capillaries, then they release the reactive oxygen species, proteases, and all of those cytotoxic components that they contain, which causes the damage of the pulmonary capillary endothelium. When we damage pulmonary capillary endothelium and subendothelial membrane, then we get increased vascular permeability in the pulmonary capillaries, and therefore there is a leakage of the fluid rich in protein from the pulmonary capillaries into the alveoli. All of that protein, which is leaked out, just lines up the alveolar lumen, and this is how we get the hyaline membranes in the alveoli of a patient with ARDS. If, let's say, the patient unfortunately dies due to ARDS, and then we do the autopsy, if we do the tissue sampling of the lung, we will see these hyaline, that is pink, membranes inside the alveoli, which correspond to that protein-rich fluid. Another very important thing about these hyaline membranes is that they wash out the pulmonary surfactant. We have already talked about pulmonary surfactant in our respiratory, I think, anatomy episode. I'm not sure, but we definitely have talked about it. So let me ask you a question. If hyaline membrane washes out the pulmonary surfactant, what will happen to the compliance of the lung? Will it increase or will it decrease? I hope you're telling me, guys, that pulmonary compliance will decrease, and in contrast, the elasticity will go up. It means that the alveoli will have an increased tendency to collapse. And this is one of the major problems in ARDS, because this is the mechanism of how the patients with ARDS develop atelectasis. Since there is decreased amount of surfactant inside the alveoli, then the collapsing pressure in the alveolus increases, and that causes diffuse atelectasis. Another very high-yield concept related to ARDS is that pulmonary edema caused by leakage of the protein-rich fluid inside the alveoli is non-cardiogenic. In other words, there is no pathology of the heart. It's not the left heart failure that causes fluid leakage in the pulmonary interstitium and the alveoli. No, it's the damage of the pulmonary capillary endothelium and an increased vascular permeability that causes exudation of the fluid. Now, how can we differentiate cardiogenic from the non-cardiogenic pulmonary edema? Do you remember that, guys? Are you telling me that the main parameter to differentiate between these two types of pulmonary edema is pulmonary capillary wedge pressure? If you are absolutely correct. Pulmonary capillary wedge pressure is the pressure within the pulmonary capillaries, to say it very simply. And if the patient has left heart failure, then the blood will back up from the left ventricle into the left atrium, pulmonary veins, into the pulmonary capillaries, meaning the PCWP will increase in the left heart failure. However, when the patient has non-cardiogenic pulmonary edema, for example ARDS, the PCWP will be absolutely normal. The cutoff value that I would like you to remember, guys, is 18. Different sources mention the different cutoff values, but 18 is a comfortable value which is most commonly used, as I have observed, among the other medical students. Let's discuss the diagnostic criteria of the ARDS. And here I'd like to remind you a very good mnemonic that the first state has come up to summarize the diagnostic criteria. We have the abbreviation ARDS, right? And the first letters of this abbreviation can be used to remind us of the diagnostic criteria. A stands for abnormal chest X-ray. Let me give you a question, guys. What do you think the chest X-ray will show in a patient with ARDS? That's right. There will be the bilateral diffuse opacities due to the exudation of that protein-rich fluid. Sometimes doctors refer to the ARDS lungs as complete whiteout of the lung. R stands for the respiratory failure within 1 week of the alveolar insult. D stands for decreased PaO2 to FiO2 ratio at less than 300. Let's talk about this ratio. We know that PaO2 is partial pressure of oxygen in the arteries, while FiO2 is the fraction of the inspired oxygen. For example, on the room air, the FiO2 is normally 21%. And we know that the more oxygen we inhale, the more oxygen diffuses from the alveoli into the blood. Therefore, increasing the FiO2 should normally increase the PaO2. But diffusion of the gases across the alveoli depends on the thickness and the other characteristics of the diffusion membrane. Now, can you please tell me what happens to the thickness of the diffusion membrane in ARDS? I hope you're saying that the membrane thickness increases because we already discussed how hyaline membranes line up the alveolar lumen. So if the diffusion membrane increases in thickness, then diffusion rate of almost all the gases, including oxygen, will decrease. This is why, even in the case of normal FiO2, PaO2 will not increase sufficiently, and their ratio will be smaller than normal. This is why we say that one of the diagnostic criteria for ARDS is PaO2 to FiO2 ratio less than 300. And finally, S stands for symptoms, and this criteria says that the symptoms should not be due to heart failure or fluid overload. And this goes back to our discussion several minutes ago when we talked about the cardiogenic pulmonary edema. Both heart failure and the fluid overload cause cardiogenic pulmonary edema with increased PCWP. But in order to diagnose somebody with ARDS, this patient should have non-cardiogenic pulmonary edema. We already mentioned what the consequences are for the ARDS, right? We said that lung compliance will go down, and in contrast, elasticity will go up. We have also talked about how gas exchange will be impaired, and finally, what we have not discussed so far is that the patient with ARDS might develop pulmonary hypertension. Before we talk about this in a little bit more detail, let me ask this. Why do you guys think the patient with ARDS might develop pulmonary hypertension? Are you saying that diffuse pulmonary hypoxia causes hypoxic vasoconstriction? If you are, that's absolutely true. We mentioned that there is defective diffusion of the gases, including oxygen, all over the lungs in someone with ARDS. And we also know that the lungs are different from any other organ system in the body in a sense that lungs are characterized by pulmonary vascular dilation in case of hypoxia. It's characterized by pulmonary vascular constriction in case of hypoxia. And that diffuse pulmonary vasoconstriction increases the afterload for the right ventricle, which finally results in the concentric right ventricular hypertrophy and cor pulmonale if it persists for a considerable amount of time. And lastly, let's discuss the management of the ARDS. We mentioned several conditions which can result in acute respiratory distress syndrome. Therefore, the mainstay of treatment is to treat the underlying cause of ARDS. If the cause of ARDS is sepsis, then we should treat the sepsis first with, let's say, IV antibiotics, IV fluids, possibly vasopressors, whatever we will need. And definitely the management depends on the specific underlying etiology of the ARDS. But what about the lungs? How can we alleviate the respiratory failure in a patient with ARDS? Patients with ARDS are usually treated with mechanical ventilation, and during mechanical ventilation, we should maintain low tidal volume and high PEEP, or positive and expiratory pressure. Let's explain why we should maintain these parameters at these levels. Tidal volume should be low because if we increase the tidal volume, then the patients with ARDS are at higher risk for barotrauma, or trauma due to increased air pressure in the lungs. And they might develop traumatic pneumothorax. We'll definitely talk about the pneumothorax in this episode later, but I think that there will be enough in this discussion. As for the PEEP, positive and expiratory pressure is the pressure of the air inside the alveoli at the end of expiration. This is why it's called positive and expiratory pressure. We mentioned that hyaline membranes lining up the alveolar lumen wash out the surfactant, which causes increased tendency of the alveoli to collapse. This is why collapsing pressure increases. So we need to increase the distending pressure, which will oppose increased collapsing pressure. And in order to increase distending pressure, we need to increase positive and expiratory pressure, which is practically the distending pressure. And therefore, increased PEEP will keep the alveoli open during the expiration. This was discussion about the ARDS. Let's move on to the sleep apnea. We should first take a closer look at the term itself, sleep apnea. A is a negative prefix and it means no, and nea means breathing. Apnea means no breathing. And sleep apnea is the episodes during the sleep when the patient stops breathing for at least 10 seconds per each episode. When the patient stops breathing for that time, then certainly carbon dioxide is going to accumulate in the body and there will be hypoxemia in that particular period of apnea. And this will stimulate the medullary respiratory center, and then the patient will start breathing normally and possibly vigorously. The patient, after the episode of apnea, wakes up, but he or she doesn't wake up completely. They might not remember that they wake up multiple times during the night, but still they become slightly conscious after the episodes of apnea, and then they go back to sleep. But you can imagine that those multiple episodes of waking up at night disrupts the overall sleep. They have disrupted sleep, and the patients with sleep apnea don't get refreshing sleep. This is why common symptoms for which patients apply to the doctors include daytime sleepiness and fatigue. Patients commonly report that they are drained out of energy. They can sometimes they cannot even drive the car, or they cannot do their job, and it might be related to sleep apnea. The way we diagnose any type of sleep apnea is by sleep study or polysomnography. To say it simply, we need to observe the patient while she or he is sleeping so that we can find out if the patient has those apnea episodes. Before we move on to discussing the specific subtypes of sleep apnea, let's talk about the common complications, because as I mentioned, they are common for both types of the sleep apnea that we're going to discuss. First, patients with sleep apnea have nocturnal hypoxia due to the episodes of apnea. When we have hypoxia, this is a physiologic stress for the body, and this is why sympathetic nervous system gets activated. Now, when sympathetic nervous system gets activated, can you please tell me what happens to the vascular tone diffusely in the body? In other words, do our vessels constrict or dilate in case of increased sympathetic tone? I hope that you're telling me that the vessels constrict. And that's right. So when we have increased sympathetic drive, we have diffuse vasoconstriction, and this increases blood pressure. Let me remind you from the cardiac physiology that the blood pressure, mean arterial pressure, equals to cardiac output times total peripheral resistance, and diffuse vasoconstriction increases the total peripheral resistance. Therefore, patients with sleep apnea commonly have systemic hypertension. In addition, they also commonly have the pulmonary hypertension. Now, let me ask this rather than telling you the explanation. Why do you guys think that the patients with sleep apnea might develop pulmonary hypertension? Hmm. That's right. We already mentioned while discussing the ARDS that the lungs are different from the other organ systems in a sense that there is pulmonary vasoconstriction in response to hypoxia. And when the patients have apnea episodes at night, they have diffuse pulmonary vasoconstriction, which might persist after the patient has the sleep apnea for a considerable amount of time. And this will definitely result in pulmonary hypertension. Finally, there is another important complication of sleep apnea, which is polycythemia, or increased RBC count. Could you please tell me the mechanism by which patients with sleep apnea develop polycythemia? I hope you already have an answer, but we will definitely discuss it. Just like we talked about the other complications in sleep apnea, everything arises from nocturnal hypoxia. When we have hypoxia, this will cause decreased oxygen delivery to the kidneys. Now, can you please remind me which hormone is produced in the interstitial fibroblasts of the peritubular capillary bed? I really hope you're saying that it's EPO, erythropoietin. So hypoxia stimulates the release of erythropoietin, and then this EPO stimulates the bone marrow to produce more RBCs. Therefore, these patients with sleep apnea will have appropriate absolute polycythemia. Appropriate because the polycythemia developed in response to hypoxia, and it's absolute polycythemia because the red blood cell mass also increased, not only the concentration but also the total amount of the red blood cells in the body increased. Now it's a good time to discuss the different types of sleep apnea, and we will start with obstructive sleep apnea, or OSA. Let's think about the name for a second. It's obstructive sleep apnea. In other words, there is some kind of obstruction either in the nasopharynx or oropharynx, which causes decreased airflow at night, because at night we have decreased tone of all of our muscles, including our laryngeal muscles. Therefore, if the patient has some reason of obstruction in his or her nasopharynx or oropharynx, then this will exacerbate the lowered tone of the laryngeal muscles. However, the patients still have the respiratory effort. In other words, their respiratory center in the medulla works perfectly, and when they cease breathing, the respiratory medullary center detects hypoxia very rapidly, and they do have the respiratory effort. They try to breathe in, but they still have this obstruction. It's very important to remember that patients with OSA usually have normal PaO2 during the day. And the mechanism for this goes back to what we have discussed probably several seconds ago, that at night we have decreased tone of all of our muscles, including the laryngeal muscles. But when we are awake, then the tone of our muscles is increased compared to the sleeping state. So we can maintain to some degree the patency of the larynx and the tone of the laryngeal muscles. And there is less obstruction of the airways when the patients with OSA are awake. The most common reason for obstructive sleep apnea in adults is excessive parapharyngeal or oropharyngeal tissue. Obstructive sleep apnea is quite common in obese individuals because when the patient is obese, there is excessive fat deposition around the neck, and that fat deposition all around the neck can actually cause external compression of the larynx during the night, which will result in obstruction. In contrast, the reason for obstructive sleep apnea in children is different. In children, well, the child might be obese, and therefore obesity might also be the cause of obstructive sleep apnea in a child. However, a more common cause is adenotonsillar hypertrophy. In other words, there is hypertrophy of the pharyngeal tonsils or the palatine tonsils, which result in the obstruction of the airways at night. How do we treat the obstructive sleep apnea? First, we definitely try to do behavioral and non-invasive management. And for this, we ask the obese individuals to lose the weight, because the more weight we lose, the less parapharyngeal tissue there will be around the neck, and therefore there will be less obstruction at night. However, weight loss is not an immediate process. It takes time, and it takes months and possibly years. And we have a patient who has hypoxia. And let's say that we have a patient who has obstructive sleep apnea with the complications like systemic and pulmonary hypertension. In that case, we cannot rely only on the weight loss. We should also find a quicker solution for this patient, and this quicker solution is the Cpap, or continuous positive airway pressure. This is the special device that the patient gets on his or her face, and continuous positive air pressure maintains continuously positive pressure inside the alveoli. In other words, inside the alveoli and the airways. In other words, it prevents the collapse of the airway along its whole course. There is a new way of treating obstructive sleep apnea as well, and this procedure that I'm talking about is hypoglossal nerve stimulation. Before we discuss this in detail, could you please tell me how the hypoglossal nerve stimulation can possibly treat the obstructive sleep apnea? I believe that you already have an answer, but if you don't, that's also okay, because we will discuss it now. We know that hypoglossal nerve innervates all the tongue muscles except the palatoglossus muscle, right? It means that the hypoglossal nerve also innervates the genioglossus muscle, which causes protraction of the tongue forward. When we lie down at night, the tongue moves a little bit posteriorly, and therefore posteriorly displaced tongue can contribute to the obstruction of the oropharynx and exacerbation of the symptoms of obstructive sleep apnea. If we stimulate hypoglossal nerve, this will cause contraction of the genioglossus muscles to some degree, and therefore the tongue will move forward even when we lie down, and that will just create enough room for the air to go into the lungs, and we will prevent the apnea episodes. If the reason for obstructive sleep apnea is adenotonsillar hypertrophy, then we can certainly do the tonsillectomy to relieve that obstruction. Okay, this was obstructive sleep apnea. Now let's move on to central sleep apnea, or CSA. And once again, before we dive into that diagnosis, let's talk about the name itself. It's central sleep apnea. In other words, it's sleep apnea due to central nervous system problem. And specifically, this CNS problem is impaired medullary respiratory center. The medullary respiratory center is depressed, or it cannot detect hypercapnia in a timely manner. What can cause the depression of the respiratory medullary center. First of all, if the patient takes the illicit drugs, which are CNS depressants, let's say opioids, barbiturates, they can cause central sleep apnea. At the same time, if the patient has CNS injury due to any cause, that can also result in CSA. And finally, congestive heart failure is one of the highest yield causes of the central sleep apnea. The reason here is that congestive heart failure, especially the higher stages, result in decreased cardiac output and hypoxia of the respiratory medullary center. Insufficient blood flow with the oxygen and the nutrients to the medullary center for the respiration results in its depression and dysfunction, which is why the patient with CHF can also develop central sleep apnea. Central sleep apnea can be associated with a very specific pattern of breathing, which is called Cheyne-Stokes respirations. Cheyne-Stokes respirations are the oscillatory respirations alternating between complete apnea to severe hyperpnea. Let's talk through this and explain what it means. This is when the respiratory medullary center cannot detect the hypercapnia during the episodes of the apnea timely. And let's say the patient has apnea, right? In this case, the carbon dioxide accumulates in his or her body, but respiratory medullary center needs to see a very high level of carbon dioxide in the blood in order to stimulate breathing in the patient. And when the carbon dioxide levels goes too high, this is when the patient starts breathing, and the patient breathes very deeply and very vigorously to blow off all of that carbon dioxide that he or she accumulated during the episodes of apnea. I would really like to recommend you to search, to Google the Cheyne-Stokes respiration and possibly watch the YouTube videos, because once you see how the patient breathes in this case, you will never forget what the Cheyne-Stokes respirations actually look like. The treatment for central sleep apnea is positive airway pressure, or Cpap, just like for the obstructive sleep apnea. The last condition that I'd like to discuss with you here, guys, is obesity hypoventilation syndrome, or OHS. Obesity hypoventilation syndrome is not entirely sleep apnea. It might be associated with obstructive sleep apnea because they are commonly caused by the same thing, but obesity hypoventilation syndrome itself does not happen during the sleep. Okay, OHS is also known as Pigwikian Syndrome. The patients with obesity hypoventilation syndrome certainly are obese, and usually their BMI is at least 30. In that case, they have so much adipose tissue on their chest that it's hard to move all of that adipose tissue on every cycle of respiration, which is why patients with OHS have very shallow breaths. If the breaths are very shallow, it means that we are filling up mostly the dead space or conducting zone of the respiratory system, and there is insufficient gas exchange in the alveoli. Consequently, patients with obesity hypoventilation syndrome will also have the daytime decrease in arterial partial pressure of oxygen, and they will also have increase in PaCO2. They might also have the same problem at night, which will most likely be caused by the obstructive sleep apnea. As for the treatment of obesity hypoventilation syndrome, well, the treatment is almost the same as for the obstructive sleep apnea. We recommend the patient to lose the weight because losing weight really helps. It releases all of that burden and the pressure of the excessive adipose tissue, and it will allow the patient to take the deeper breaths. But at the same time, we need a quicker resolution, and for this we will use the Cpap. This was discussion about the sleep apnea. We will now discuss the pulmonary hypertension. Before we talk about the different types and the groups of pulmonary hypertension, we should first define what it actually is. Pulmonary hypertension is a high mean pulmonary artery pressure, and the cutoff value is 20 millimeters of mercury. So if mean pulmonary arterial pressure, please take a notice at the fact that it's a mean pulmonary arterial pressure, not systolic, not diastolic, but mean. Mean pulmonary pressure should be more than 20 millimeters of mercury at rest. Now, what will pulmonary hypertension result in terms of pulmonary vascular remodeling? Well, when there is high blood pressure affecting the blood vessels, first of all, there is intimal fibrosis and dysfunction. Intima, let me remind you, is the innermost layer of the blood vessels, and when there is consistently high blood pressure, it undergoes thickening and hardening in order to contain that blood with the high pressure inside the vessel. At the same time, there is usually a hyperplasia of the smooth muscle in the media. Let me also remind you that the tunica media is the middle layer of the blood vessels. Hypertrophy and hyperplasia of the medial smooth muscle and the intimal fibrosis will finally result in narrowing of the lumen of the pulmonary vessels. Now here's a question for you guys. What do you think will happen to the pulmonary vascular resistance of a patient who has developed pulmonary hypertension? Are you saying that pulmonary vascular resistance increases? If you are absolutely right. And then if the patient has increased pulmonary vascular resistance in terms of pulmonary hypertension, what will happen to the right ventricle? I hope you're saying that the right ventricle will undergo concentric hypertrophy, because this is a pressure overload state, not the volume overload state. And then finally, if the patient has untreated pulmonary hypertension due to any cause, this patient can develop the right heart failure. Let's now discuss the different groups of the pulmonary hypertension according to the WHO. We have 5 different groups, and let's discuss which etiologies are united under which group. Group 1 pulmonary hypertension is also known as pulmonary arterial hypertension, and it mostly involves the heritable causes of the pulmonary hypertension. Before I say this, let me ask you a question, and I'll be very proud if you have an answer on this question. Zoosemmeliers, could you please remind me the mutation of which gene increases the risk for pulmonary arterial hypertension? I hear you. I hear you saying the BMPR2 inactivating mutation. BMPR2 stands for bone morphogenetic protein receptor 2, and this receptor normally inhibits the smooth muscle proliferation around the blood vessels. So if we have inactivating mutation in the BMPR2 gene, it means that the gene product can no longer inhibit the vascular smooth muscle proliferation. This is why the smooth muscle in the tunica media will continue to proliferate and will undergo hyperplasia, and it will narrow down the pulmonary vascular lumina. We already mentioned that pulmonary hypertension also causes the intimal defects, and it causes the endothelial dysfunction. When we destroy the endothelial cells, those destroyed cells release the vasoconstrictors, for example endothelin, which further vasoconstricts the pulmonary vessels. And when we have damaged endothelial cells, they can no longer produce vasodilators that they normally produce. In these vasodilators, I mean nitric oxide and the prostacyclin or prostaglandin I2. In addition to the inherited form of pulmonary hypertension, the other possible conditions that cause the group 1 pulmonary hypertension is the illicit drug use, mostly the use of stimulants like amphetamines and cocaine. The reason behind this is that amphetamines and cocaine result in higher norepinephrine levels due to decreased reuptake in the presynaptic terminal, and therefore they can cause pulmonary vasoconstriction as well as systemic vasoconstriction. Connective tissue diseases like lupus, rheumatoid arthritis can also result in group 1 pulmonary hypertension. Interestingly, HIV and schistosomiasis are two infections that can also result in pulmonary hypertension, and portal hypertension is another condition responsible for increased pulmonary vascular resistance. Let's move on to group 2 pulmonary hypertension. Group 2 unites the causes of pulmonary hypertension coming from the heart. Now here's a question for you guys. Which side of the heart should be affected in order for it to result in pulmonary hypertension? Is it right or left? I really hope that you're saying the left side of the heart. The reason for this is that the lungs are behind the left heart in terms of the circulation, right? When we have either systolic or diastolic dysfunction of the left heart, this is when the blood or pressure, depending on whether it's systolic or diastolic dysfunction, backs up in the pulmonary veins and pulmonary capillaries, and that will increase the pulmonary pressure, resulting in pulmonary hypertension. Additionally, left-sided valvular lesions can result in pulmonary hypertension. Both mitral stenosis and mitral regurgitation can result in this condition, but also aortic stenosis and aortic regurgitation can result in backflow of the blood and pulmonary hypertension. The way I remember that group 2 unites the cardiac causes of the pulmonary hypertension is that we have two sides of the heart. We have left and right. So group 2, two sides of the heart. Well, that's my mnemonic, and you are totally welcome to use it if that helps you. And now let's move on to the group 3 causes, like group 3 of the pulmonary hypertension. So group 3 involves the primary lung diseases or hypoxia, which causes pulmonary hypertension. Let's say that the patient has COPD. In case of COPD, especially when it involves emphysema, the patient develops hypoxia and hypoxemia first, and then hypoxia due to destruction of the respiratory zone. And we mentioned several times in this episode that pulmonary vessels undergo vasoconstriction in response to hypoxia. If we have constant hypoxia in a patient with COPD, then we have constant pulmonary vasoconstriction, which will finally result in pulmonary hypertension. Additionally, if the patient has interstitial fibrosis, which is nowadays called diffuse parenchymal lung disease, this will also result in hypoxia due to increased thickness of the diffusion membrane. And then hypoxia, in turn, will result in pulmonary vasoconstriction with the mechanism that we just described. Even the other causes of hypoxia can result in group 3 pulmonary hypertension. Let's say that the patient has obstructive sleep apnea. We have already discussed OSA in this episode, right? If the patient has OSA, then she or he has hypoxia and hypoxemic pulmonary vasoconstriction, which, if persistent, can result in pulmonary hypertension. Let's also imagine someone who lives at a high altitude. Let's say you live in Colorado or somewhere at a very high place. In that case, there is decreased pressure of the inspired oxygen, not necessarily the fraction of the inspired oxygen, but the pressure. And therefore, alveolar partial pressure of oxygen goes down, and this will result in decreased arterial partial pressure of oxygen and responsive pulmonary vasoconstriction. Okay, that was the group 3 of the pulmonary hypertension etiologies. Let's move on to group 4. Group 4, pulmonary hypertension, is caused by recurrent microemboli into the pulmonary vasculature. Generally, when we think about the DVT, we tend to think about those that large thrombus which develops in the proximal veins of the lower extremities, and then if they dislodge, they cause symptomatic pulmonary embolism. However, we should also know that the patient might have a small deep venous thrombosis, and if it dislodges and goes up into the pulmonary trunk and arteries, it might not cause any symptoms. It might get lodged in the pulmonary capillaries or pulmonary arterioles, but it will not cause significant symptoms. Okay, then what happens after that microthrombus is lodged in the pulmonary capillary? In order to restore the blood flow in that particular affected blood vessel, our body tries to break down the central part of the thrombus to make a new hole, and the blood will flow through that hole. But you can imagine that this new hole inside the lodged thrombus will be narrower than the original blood vessel diameter. In other words, there might be multiple constrictions if the patient has experienced several microemboli. And this reorganization of the emboli and creation of the holes inside the thrombi will result in group 4 pulmonary hypertension. Finally, group 5 pulmonary hypertension unites all the other miscellaneous causes. So if the reason for pulmonary hypertension cannot belong to any of those 4 groups that we discussed so far, then we say that the patient has group 5 pulmonary hypertension. And the causes here might be systemic, metabolic, even hematologic and oncologic. For example, if the patient has a tumor that compresses the pulmonary vasculature, that could also result in pulmonary hypertension. And this was discussion of the pulmonary hypertension. Let's talk about the digital clubbing. First of all, what is clubbing? Clubbing is when the angle between the perineum and the nail plate is increased to more than 180 degrees. So these are those puffy drumstick fingers. And nobody really knows what exactly causes digital clubbing. However, there is one prevailing hypothesis that I'd like to share with you guys because it is so much accepted that it might appear on the step 1. When the patients have digital clubbing, it's thought to be due to megakaryocytes and the platelets lodging in the digital vessels of the fingers. And when the megakaryocytes and the platelets lodge in the fingers, then they release the different growth factors, including platelet-derived growth factor, or PDGF, and VEGF, or vascular endothelial growth factor. These 2 growth factors cause the proliferation of the blood vessels and connective tissue, and therefore they cause enlargement, the visible enlargement of the tissue. This is what we see externally. I mean the clubbing itself. The clubbing can be acquired, and most of the times clubbing is usually acquired, but it can also be hereditary. We will focus more on the acquired causes of the digital clubbing, but before we do this, let me make one general assumption which works most of the times. Digital clubbing is most commonly caused either by the respiratory disease or cardiac disease. So it's either lungs or heart. It's not an absolutely correct assumption because digital clubbing can be caused by the other causes as well, but still lungs and heart are the most common ones. From the respiratory diseases, conditions like pulmonary fibrosis, bronchiectasis, lung cancer can all cause digital clubbing. From the hereditary point of view, cystic fibrosis can also result in digital clubbing because cystic fibrosis itself causes bronchiectasis due to recurrent infections. As for the cardiovascular diseases, digital clubbing is common in patients who have, let's say, cyanotic congenital heart disease or right to left shunt, which results in systemic hypoxia and the recruitment of those megakaryocytes and the platelets. And the pulmonary infections like abscess or tuberculosis can also cause the digital clubbing. However, it's very interesting and it's worth mentioning that digital clubbing is not usually associated with COPD or asthma. In other words, patients with either of these two conditions usually don't have digital clubbing. I know that was short, but I think it was still a high-yield discussion about the digital clubbing. Let's move on to the atelectasis. And just like we do for all the other conditions, we will first define the meaning of the atelectasis and then we'll talk about the various subtypes of this condition. Atelectasis means alveolar collapse due to some underlying reason. And when the patient has atelectasis, this can be manifested as, let's say, dyspnea, hypoxemia, and if we perform the chest x-ray on a patient with atelectasis, we will see increased lung density in a specific segment or even lobe or even lung in case of severe causes of atelectasis like tension pneumothorax. And in increased lung density, I mean increased opacity of the lung. Since the area with atelectasis does not contain air, then that area looks whiter than the normal lung tissue, which is full of air and which looks darker or black. This was the general definition of atelectasis, but it is more important to know the different causes and the types of atelectasis. There are 4 different types of this condition: obstructive, compressive, cicatricial, and adhesive. Let's start with obstructive atelectasis. The name itself is self-explanatory. Obstructive atelectasis develops because there is some kind of obstruction in the bronchi or bronchioles that then results in atelectasis. Let's imagine that there is, suppose, a bronchial tumor in the bronchus. If there is a bronchial tumor completely obliterating the bronchial lumen, it means that the air, that the lung segment distal to that obstruction is not filling up, and the air that is in the distal lung segment is resorbed time by time by the blood going through the pulmonary vessels. And gradually this distal segment will collapse because there will be no more air in that segment. This is what obstructive atelectasis is all about. But then obstruction can be caused not only by the bronchial tumor, but it can be due to, let's say, foreign bodies. It can be due to mucus plug in someone with either COPD, specifically chronic bronchitis, or asthma. And yeah, so mostly foreign bodies, mucus plug, and the tumor cause the obstructive atelectasis. And in case of, let's say, tumor, the atelectasis will always be in the same segment or in the same lobe, if the atelectasis is recurrent, of course, because the bronchial tumor is in that fixed position and it causes the depletion of air to its distal lung segment. Let's move on to the compressive atelectasis. And once again, the name implies what it's all about. Compressive atelectasis is caused by a compressive force in the pleural cavity. What can compress the lungs from the pleural cavity, guys? Do you have an answer in that? are you saying that either the mass, fluid, including blood, or the air can compress the lungs from the pleural cavity? If you are totally right. Let's discuss the examples of these three causes. We have discussed mesothelioma in our previous respiratory pathology episode, but let's remind ourselves of what mesothelioma is. This is the tumor of the mesothelium caused by long-term asbestos exposure. So mesothelioma grows in the pleural cavity, and if it grows sufficiently, it can eventually compress the alveoli, and it can cause the compressive atelectasis. Let's say that the patient has heart failure, and we see pleural effusion, bilateral pleural effusion on the chest x-ray. If pleural effusion is very massive, it can exert sufficient compressive force on the alveoli in order to collapse those alveoli. And this will also be an example of compressive atelectasis. In terms of the air, well, if we have the pneumothorax, specifically tension pneumothorax, this is when the risk for compressive atelectasis is highest if we take all of the other types of the pneumothoraces. And we'll definitely discuss pneumothorax in a great detail in this episode. But before that, let's get back to the atelectasis and let's discuss the final type of the atelectasis, which is adhesive atelectasis. Adhesive atelectasis is caused by lack of surfactant. And lack of surfactant itself can be caused by different conditions. Let's say that we have a person with sepsis that developed ARDS. We already mentioned how ARDS just washes out the surfactant. And if that person develops atelectasis, it will be classified as adhesive atelectasis. Let's take another example. Let's say that we have a premature baby who is born with the respiratory distress, cyanosis, grunting, hypoxia. What do you guys think about? I hope you are thinking about the neonatal respiratory distress syndrome, which is due to insufficient surfactant production in the preemies. In that case, since we don't have enough surfactant, there is higher collapsing pressure. In other words, the walls of the alveoli tend to collapse and tend to adhere to each other. This is why we call this type of atelectasis an adhesive atelectasis. Okay, this is how we wrapped up the discussion about the atelectasis. Let's discuss the pleural effusions. The pleural effusion is accumulation of the fluid in the pleural cavity between the parietal pleura and the visceral pleura. Before we talk about the different types of the pleural effusion, let's discuss what common symptoms the pleural effusion can cause. The pleural effusion can result in insufficient lung expansion due to all of that fluid, and therefore the patient with pleural effusion might have, let's say, shortness of breath, might even have a hypoxia due to hypoxemia if the pleural effusion is massive or bilateral. The way we treat the pleural effusion is via thoracentesis. Thoracentesis means to insert the needle in the intercostal space and to take out the pleural fluid either therapeutically or diagnostically. If the pleural effusion is very minimal, and if the cause of the pleural effusion is almost 100% clear from the patient's history, let's say that the patient has heart failure and we see bilateral pleural effusion on the chest x-ray, then we don't even have to drain the pleural fluid via thoracentesis. We can apply the other options in the management like diuretics. However, if pleural effusion is massive enough to cause the respiratory symptoms, or if we don't know or we are not sure about the exact cause of pleural effusion, this is when we can tap the thorax and we can have this fluid sample in order to check for the cell count, the specific type of the leukocyte, whether it's lymphocyte or neutrophil. We can also check the glucose, pH, and so on and so forth. Okay, and we should also know that the thoracentesis can occur in different locations. For example, if we do thoracentesis in the midclavicular line, then, if I remember correctly, we should use the 8th intercostal space. That is the space between the 8th and 9th ribs. And if we are performing the injection, intercostal injection for the thoracentesis, then we should always try to inject the needle above the ribs in order not to damage the neurovascular bundle which runs along the inferior border of each rib, which consists of the intercostal vein, artery, and the intercostal nerve. In contrast, if we want to perform the intercostal nerve block, this is exactly when we need to inject the syringe right below the rib, because this is where the intercostal nerve runs through. Okay, let's get back to the pleural effusions. Pleural effusion can be of different types. We can have an exudate, it might also be a transudate, and finally, pleural effusion might be lymphatic, which is also called chylothorax. The first question that we need to address here is how we differentiate exudate from transudate. For this, we have light criteria, knowing of which is an extremely high yield for both step 1 and step 2 CK. So I would really like to recommend you that you pay your attention to the light criteria. We know that exudate generally is cell-rich and the protein-rich fluid. And since exudate is cell-rich, it looks cloudy. Generally, cloudiness of the fluid is determined by the cell count in that fluid. But at the same time, it is protein-rich. In contrast, the transudate is cell-poor and the protein-poor fluid. And since the transudate contains a very low cell count, it's clear, in contrast to the cloudy. And at the same time, we already mentioned that it contains a very, very minimal amount of the protein. Let's discuss the light criteria first, and then we will discuss what conditions can cause exudative, transudative, or lymphatic pleural effusions. There are 3 light criteria, and the clinical significance of the light criteria is that if the patient meets even at least 1 criterion from here, this patient's pleural effusion is automatically an exudate. To put it in other words, we don't have to have a patient who meets all 3 criteria from these light criteria. Even at least 1 criteria is enough to diagnose the pleural effusion as an exudative one. Okay, now let's move on to the causes of the different types of the pleural effusion. What I would like you to remember is that exudative pleural effusion is almost always associated with either infection, inflammation, or cancer. Let's say that the patient has mesothelioma. We mentioned in the previous episode of the respiratory pathology that mesothelioma is characterized by the exudate, which is usually hemorrhagic. If the patient has TB and has pleural effusion, this pleural effusion will also be an exudate, which will have increased concentration of the adenosine deaminase. It's commonly used as a marker for the tuberculosis infection. Let's also mention the patient who has, let's say, lobar pneumonia and has pleural effusion in addition to pneumonia. In this case, the pleural effusion is called parapneumonic effusion, and the parapneumonic effusion is also an exudate caused by the leakage of proteins and bacteria in the fluid from the pulmonary vasculature into the pleural cavity. Okay, now the exudate is commonly drained because there is a risk of infection, meaning exudate can be complicated by bacterial invasion, and it can be transformed into empyema, which is the pus and the bacteria in high amounts in the pleural cavity. Guys, I think I forgot to discuss the different light criteria, and we'll definitely do it after discussing the causes. I'm so sorry, I just forgot to discuss them in detail, but we'll definitely do it. Let's move on to the transudate. Transudate can be caused by either of these two mechanisms. It might be caused by increased pulmonary vascular hydrostatic pressure or decreased oncotic pressure. Let's think about what can increase the hydrostatic pressure. Hydrostatic pressure is the pressure that the plasma exerts on the vascular wall. If we have increased amount of the blood in the pulmonary vasculature, that can definitely increase the hydrostatic pressure. Can you tell me the cardiac cause of the pleural effusion? Are you saying the left heart failure? If you are, you're totally correct, because when we have left heart failure, then the blood and the pressure will back up from the left ventricle, left atrium, into the pulmonary veins, into the pulmonary capillaries, finally causing increased hydrostatic pressure and the transudation of the fluid. Or let's say that the patient has sodium retention with impaired aldosterone escape mechanism. In that case, increased sodium is also accompanied by expanded intravascular volume, which will exert the higher hydrostatic pressure on the pulmonary vasculature. The second cause that we discussed, that we mentioned, is decreased oncotic pressure. Let me remind you that the oncotic pressure in the plasma is defined mostly by the plasma proteins, and from all of the plasma proteins, it is mostly dependent on the albumin. Now, oncotic pressure and the albumin concentration in the plasma are directly proportional to each other. In other words, if the albumin goes down, then oncotic pressure goes down too, and therefore we can no longer hold the fluid in the vasculature. And so if blood that is in the pulmonary vessels has decreased oncotic pressure, just like the whole blood for sure, then we will have the transudation of the fluid in the pulmonary interstitium and even alveoli. Then the question is, what can cause a decrease in the albumin concentration? Can you guys tell me what conditions you think about in this case? Are you saying nephrotic syndrome or cirrhosis? I hope you are, because decreased albumin in the plasma can be either due to decreased production or increased wasting. In nephrotic syndrome, patients lose a very high amounts of protein in their urine, including albumin. And in case of cirrhosis, the synthetic liver function is decreased, and therefore the liver can no longer synthesize enough amounts of the albumin. And then the final type of pleural effusion that we need to discuss is lymphatic pleural effusion, or the chylothorax. And chylothorax is usually caused by trauma to the thoracic duct, which contains the lymph or lymphatic fluid. And when there is thoracic duct injury, either during the trauma or during surgery, or let's say we have mediastinal malignancy which compresses the thoracic duct, this is when we can find the chylous fluid in the pleural cavity. And chylothorax is usually white and milky. do you guys know the reason why chylothorax looks milky? It is because it contains lots of triglycerides. And the reason for this, if we go back to the biochemistry, is that thoracic duct drains the lymph from almost whole body except the right upper half of the body above the diaphragm, and we know that the lymphatic system carries the chylomicrons before they go into the venous blood system. This is why the lymphatic pleural effusions are white, milky, and on the analysis we will see increased triglycerides. Now let's get back to the Leitz criteria that we forgot to discuss in the beginning of this discussion. There are three criteria, as we already mentioned, and the first one is the pleural fluid protein to serum protein ratio more than 0.5. If the patient meets this criterion, then his or her pleural effusion is an exudate. Second criterion sounds like this. This is a pleural fluid LDH to serum LDH ratio more than 0.6. And the logic here is the same as for the first criterion. LDH, or lactate dehydrogenase, is an enzyme, and the enzymes are proteins. So if there is considerably high amounts of protein in the pleural cavity relative to plasma, it means that this pleural effusion or pleural fluid is rich in proteins, and therefore this is an exudate. And the final criterion in the Leitz criteria is the pleural fluid LDH should be more than 2/3 of the upper limit of the normal serum LDH. Normal serum LDH has the different upper limits depending on which unit of measurement we use. But let's say that the upper limit is 90. In that case, the 2/3 of the upper limit of serum LDH is 60. So if pleural fluid LDH concentration is more than 60, then we can say that this patient's pleural effusion is an exudate rather than a transudate. And this was discussion about the pleural effusions. The final topic in our today's episode is the pneumothorax. Let's talk about the name itself, and it'll become very clear what the pneumothorax is all about. Pneumothorax. Pneumo means air. Thorax means thoracic cavity, specifically the pleural cavity. Therefore, pneumothorax means air accumulation in the pleural cavity. And this is exactly what the pneumothorax is. This is the accumulation of the air in the pleural cavity due to some underlying cause. Before we discuss the different types of the pneumothoraces, we should first talk about the common signs and symptoms of someone with the pneumothorax. Let's imagine that there is air in a single pleural cavity and it compresses the lungs. This patient will have the chest pain due to the lung compression. At the same time, the patient with pneumothorax will have asymmetric chest expansion. In other words, the collapsed lung will not expand normally, but the unaffected lung will expand sufficiently. And therefore, you can imagine a person who is breathing and his or her one side of the chest is expanding normally, but the other side looks static, so it doesn't move almost. Additionally, the patient with pneumothorax will have hyperresonance on the affected side. The resonance is determined by the percussion of the lungs, and normally the lungs should be resonant due to the air that is inside the alveoli. If we have hyperresonance, it indicates excessive amount of air, but in this case in the pleural cavity. Therefore, if you hear the term hyperresonance in terms of the lung exam, always think that there is extra air, which should not be, in the pleural cavity. The patients with pneumothorax also are characterized by decreased tactile frametest. Guys, can you please remind me what the tactile frametest is? Tactile frametest is transmission of the vibration from the lungs to the chest wall. And we can check the tactile frametest by putting our hands on the patient's back and asking the patient to say 99. In that case, tactile frametest should be moderate. It should not be decreased and it should not be increased. Now, why does pneumothorax cause decreased tactile frametest? Could you also answer that question? I hope you already did, but nevertheless, we will discuss it for sure. When there is a pneumothorax, it means that the distance between the chest wall and the lung increases. And since the sound has to travel a longer distance in order to reach the chest wall, then the sound is dissipated along that distance while it travels through the pleural cavity. This is why tactile frametest is decreased in the patient with pneumothorax. And the breath sounds will also be decreased because, as we already discussed in this episode, pneumothorax can cause compressive atelectasis. Now it's a good time to talk about the different types of the pneumothoraces. We can classify the pneumothorax according to the cause and according to the severity. According to the cause, we can have primary spontaneous pneumothorax, secondary spontaneous pneumothorax, and traumatic pneumothorax. While based on the severity, we can have simple pneumothorax and the tension pneumothorax. And let me tell you one thing. Pneumothorax caused by any of the conditions that we mentioned right now can be either simple or tension. In other words, all of these pneumothoraces, so primary spontaneous, secondary spontaneous, and traumatic pneumothorax, is further subdivided into simple variant and the tension variant. Let's first discuss the classification according to the cause, and we will talk about the primary spontaneous pneumothorax. Let's think about the name just as we do for almost all the conditions, because once we understand the name, it's almost like a shortcut to all the other information that we remember about the condition. It is a primary spontaneous pneumothorax. It means that the pneumothorax happens spontaneously on its own. There's no acute trigger to the pneumothorax. And this pneumothorax is also primary. It means that it is not due to an underlying condition. Primary spontaneous pneumothorax is quite common in tall, thin, young males, especially if they smoke cigarettes. So all of these characteristics are classic for a patient who develops primary spontaneous pneumothorax. Let's repeat it one more time. This is tall, thin, young males who smoke cigarettes. They might not be smoking, and absence of smoking does not rule out the primary spontaneous pneumothorax, but still, tobacco increases the risk for primary spontaneous pneumothorax. Let's move on to the secondary spontaneous pneumothorax, and as the name implies, it is a spontaneous pneumothorax that is secondary to some underlying condition. And this underlying condition can be specific to the lungs or it can be systemic condition. Secondary spontaneous pneumothorax is commonly caused by COPD, especially if the patient has predominant emphysema. Because in emphysema, we know that the patient develops the bulla in the lungs, and those dilated bulla can rupture, causing the secondary spontaneous pneumothorax. Pulmonary infections can also result in this type of pneumothorax, and the systemic diseases that I was talking about several seconds ago can include something like Marfan syndrome, because patients with Marfan syndrome are very tall usually, and they might be of a thin physique, and they can develop the secondary spontaneous pneumothorax. Let's move on to the traumatic pneumothorax. Once again, the name tells us that this is a pneumothorax due to trauma. And then the trauma can be either blunt, penetrating, or iatrogenic. Guys, could you please remind me what the term iatrogenic means? Iatrogenic means physician induced. So it's due to some kind of medical intervention that causes something like some condition as a side effect. The blunt trauma that can cause pneumothorax can include something like the rib fracture, because when the patient has a rib fracture, those fractured segments can invert inside and they can puncture the lung, causing the pneumothorax. If the patient has a penetrating chest trauma, that can definitely cause the pneumothorax. Let's say that the patient experienced the gunshot wound. If the bullet goes through the chest wall and pierces the lung, that will definitely create this pleural valve, which will let the air inside the pleural cavity. And then iatrogenic causes of the traumatic pneumothorax are multiple. Let's say that we are placing the central line to the patient's internal jugular vein or the subclavian vein. In that case, we might actually puncture the apex of the lung. The reason is that, let me remind you, that the lung apex extends above the clavicles on both sides. So it's very susceptible to injury while we are doing manipulations on the cervical veins. Let's say that we are doing a lung biopsy. During the lung biopsy, we can also cause the puncture of the lung and escape of the air in the pleural cavity. Or let's suppose that the patient is on mechanical ventilation and we are ventilating him or her with very high tidal volumes. High tidal volumes increase the intra-alveolar pressure and inspiratory alveolar pressure to such an extent that the alveoli might actually tear up, and this might cause the air escaping from the alveolus into the pleural cavity. Okay, now that we have discussed the pneumothoraces according to the cause, let's move on to classification of the pneumothorax according to severity. As we already mentioned, we can have a simple or tension pneumothorax. Simple pneumothorax creates the pleural, let's say, valve, which is bidirectional. In other words, this pleural valve or defect is open during both expiration and inspiration. And this is why there is no net accumulation of the air in the pleural cavity. Please don't get me wrong. In simple pneumothorax, we still have accumulation of the air in the pleural cavity. This is why the patient is symptomatic in the first place. What I'm saying is that the air is not accumulating gradually or on top of each other in the pleural cavity, and therefore there is no tension on the mediastinal structures. In contrast, the tension pneumothorax is the pneumothorax that creates tension on the mediastinal structures and also on the lung. In case of tension pneumothorax, this pleural valve created by the trauma or other conditions is unidirectional. It means that it opens up when we inhale, because during inhalation, intrathoracic pressure goes down. But it closes when we try to exhale, because during exhalation, intrathoracic pressure goes up. It means that the tension pneumothorax causes a gradual accumulation of more and more and more air in the pleural cavity. And this gradual increasing amount of air will compress the lungs to a great extent. Other than the compressive atelectasis, tension pneumothorax can cause much more serious hemodynamic consequences. First of all, it can cause the tracheal deviation towards the contralateral lungs, but at the same time, it can cause the deviation of all the mediastinal structures, including the heart, towards the contralateral lungs. This will also compress the contralateral lungs to some extent because all of those mediastinal structures are now compressing the contralateral lungs, which are not affected by the pneumothorax directly, but they are still affected by pneumothorax indirectly. And probably the highest yield point on the tension pneumothorax is that it can cause obstructive shock. Before we explain the mechanism behind this, could you please tell me, why do you guys think the tension pneumothorax can cause obstructive shock? I hope you already have an answer in your mind, but if you don't, that's okay, because we are going to explain it. We already mentioned that tension pneumothorax causes displacement of all the mediastinal structures towards the contralateral lungs. And during that displacement, it causes kinking or bending of the inferior vena cava. And that kinking of the inferior vena cava causes decreased venous return to the heart. And when we have decreased venous return, well, certainly we'll have decreased cardiac output. And if cardiac output decreases very significantly, this can definitely result in the symptoms of shock. It might be severe hypotension, severe tachycardia. We might also have the jugular venous distension because increased mediastinal pressure will force the blood up into the internal and external jugular veins. Okay, this was tension pneumothorax, but what we have not discussed is the treatment of the pneumothoraces. Here's the thing. When we have a simple pneumothorax, then the treatment depends on the patient's symptoms. If the pneumothorax is very small, let's say less than 2 centimeters, if the patient has no hypoxia, and if he or she has only a slight respiratory distress, just the oxygen might be enough for the treatment of such degree of pneumothorax. However, if the simple pneumothorax causes severe respiratory symptoms, then we need to insert the chest tube and drain the air out of the pleural cavity. Now, what about the tension pneumothorax? Tension pneumothorax is a true emergency. What we do is that first we need to do the needle decompression to rapidly decrease the amount of air in the pleural cavity, and then we will continue draining the air from the pleural cavity via the chest tube placement. Needle decompression in case of tension pneumothorax is usually performed in the second intercostal space in the mid-clavicular line, either on the left or right, depending on which lungs experience the pneumothorax. And after we do the needle decompression, then we can insert the chest tube and continue drainage of the air through the chest tube. We have come to an end of our today's episode, and let's summarize everything that we have discussed today. In this episode, we have discussed several pulmonary conditions, namely acute respiratory distress syndrome, sleep apnea, pulmonary hypertension. We have also talked about the mechanism and the clinical significance of digital clubbing. We have talked about the atelectasis, pleural effusions, and finally, we summarized our episode by talking about the pneumothorax. It's very important that we remember the causes and the pathophysiology and the important treatment options for these conditions. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, Zoosemmeliers, and see you on the next episode.